Good afternoon. I would like to open the next session, which is the best oral presentation. So we have three presentations. My name is Kostas Gerasimidis. I'm Professor of Clinical Nutrition, and my co-chair is Professor David Wilson. So if I'm allowed to ask the first presenter to come to the podium, please. So this is Alexandra Hansson, and her talk is on the transabdominal bowel ultrasound and clinical outcomes over 1 year in children with newly diagnosed Crohn's disease.
Thank you. Thank you for the introduction. I'm very excited to be representing the Edmonton Pediatric IBD group and sharing these results with you. So I have no conflicts of interest. So we all know about transabdominal bowel ultrasound, but I feel like it's a very emerging tool, especially over the last 2 to 3 years. It's non-invasive. It's being used to assess at the beginning as well as monitor IBD in our pediatric patients. And there's been a lot of standardized scoring tools that have been developed more recently in the last 2 years, mostly focusing on the bowel wall thickness, so you can see in the top right corner, as well as hyperemia measured on Doppler signal in the bottom picture there. In particular, in pediatrics, I think it's an important tool to explore because there's no need for anesthesia, unlike endoscopy for our patients. There's no radiation. And as we've been talking about today already, patient and caregiver-centered care is quite important. And you can see a photo of our machine that we use in our clinic in Edmonton. And for this study, there's currently no longitudinal pediatric studies that are assessing the use of ultrasound in the clinical practice of pediatric IBD. So that led to our primary objective, which was to describe longitudinal transabdominal bowel ultrasound findings and how it relates to markers of IBD activity in pediatric patients with newly diagnosed Crohn's disease up to 1 year after they were diagnosed. And how we did this, all patients that came to our pediatric IBD clinic or were seen as new consults in our children's hospital were assessed and prospectively enrolled. And then for this study, those with Crohn's disease were included. And patients underwent a bedside bowel ultrasound. We have 2 pediatric gastroenterologists who are certified in this skill in our center. They underwent clinical assessment. We used the weighted PCDI in the study. They had blood work, including CRP and ESR, and fecal calprotectin, as well as endoscopy, and we use the SCSCD scoring system. And you can see the timeline of when these investigations were repeated over the first year. So for the ultrasound system, we use the SUSCD score, which was published in 2020 out of Norway, and it looks at the bowel wall thickness, measuring 0, 1, 2, or 3 points. And as soon as you hit 3 millimeters or higher, that's when you start to have abnormal findings, and you get scored those points that you can see there. And then you also look at hyperemia on the Doppler signal and looking at the number of vessels per centimeter squared, so either 0, 1, or 2. So each segment, the maximum score you can get would be 5, and then total score would be 20. As we measured the ileum, the right colon, the transverse colon, and the left colon, we excluded the rectum, as it's quite difficult to assess on transabdominal ultrasound. In this study, we had 55 patients, and everyone was followed for 6 months. 82% were followed for the full 12 months, and over 2/3 were male. The median age was 12.5, and as you can see, the markers of the baseline disease severity was moderate disease, both clinically, endoscopically, and biochemically. This first graph is showing a few different things. So for the black dotted line, that is the total ultrasound score for all patients over time, from diagnosis to 12 months. And you can see that it improves with time. The other measures are showing the different bowel segments, the bowel wall thickness. And for this graph in particular, we took away those that had 2.5 millimeters or less to be able to demonstrate what the abnormal bowel segments are doing over time. And as you can see, they also improve with time in patients, and the ileum tends to be the bowel that is most affected or the thickest. And then when we look at the bowel wall thickness of the most severe bowel segment in patients, again, it improves with time in patients. And for this graph, we divided those in remission at that time point versus those not in remission. And you can see the criteria that we used there on the left. And you can see the groups start to separate and become significant starting at 3 months and going forward to 6 months and 12 months since diagnosis. This graph is showing similar data, but we're showing the total ultrasound score with time. And again, for every patient, it does improve with time, but there is that split in the 2 groups that when you look at those in remission, they have a lower total score, which becomes significant at 6 months as well as 12 months. We looked at patients that never needed biologics, and that's represented in green over time, and their total ultrasound score improves with time. in almost a linear fashion. And those that needed to be escalated to biologics after 1 to 3 months are in purple, and those that had to be escalated after 6 months are in orange. And you can see in those patients, the ultrasound shows interval worsening or lack of improvement, and then after escalation, it shows improvement. Over time, the total ultrasound score correlated significantly with endoscopic measurements, as well as clinical measurements and biochemical measurements, and this was sustained over the 12 months, especially for endoscopy and ESR. And in our cohort, we had 7 patients who needed surgery over the first year. So all 7 of these patients had ileocecal resections, and 2 also had jejunal resections. And the significant differences between patients who ended up needing surgery and those who didn't, they had worse endoscopy score for their ileum at baseline, but they also had thicker ileum when you're measuring the bowel wall thickness on ultrasound at the baseline. And 6 of these 7 patients actually had findings of obstruction on the baseline ultrasound, so that they showed an area of narrowing and proximal bowel dilatation. And when you follow the subsequent ultrasounds for these patients who do end up needing surgery, all of the ones that had that baseline obstruction had persistent obstruction until they went for surgery. And 2 patients had small collections that persisted prior to surgery as well. And then all patients after their surgery normalized their ultrasound score as well as the clinical assessment and biomarkers as well. So in conclusion, over 1 year, we found that ultrasound had sustained correlations with clinical, endoscopic, and biochemical markers of disease in children with Crohn's disease. And the thickened bowel wall, especially at baseline, as well as persistent bowel dilatations that still remain there on subsequent ultrasounds, can help identify those that are at risk of surgery. And a lack of improvement or an interval worsening on the ultrasound can help identify those that might need escalation of therapy, as well as those who might need to go on to surgery. And I think especially at that first month and that 3-month ultrasound, you can start to see the trend in patients who are continuing to improve or who are worsening or stabilizing. So I think when we think about ultrasound, I think it could be another tool that can help us increase confidence in our decision-making if we're deciding to change treatments or even thinking about surgery for our patients. There are limitations to this tool, as with any tool, so that includes cost of the machine. So I think in our clinic, we've had 2 times this year where it's needed to go for repair, as well as time. So time of the gastroenterologist, time of the patient and the family, and their appointment time. But I think there's many advantages. So it can potentially help reduce the repeated use of more expensive and resource-intensive tests. And I think especially for general anesthetic, and especially in COVID, when I know the wait list for endoscopy and MRI imaging has really increased exponentially. And also it could help identify patients who need closer follow-up. So you might need to bring them into clinic more often and repeat their ultrasound among other markers to pay attention to those, especially who may need to go to surgery. And I think we talked about this earlier in the conference as well, but this could be a tool that would help us assess transmural healing, which I think would be quite important in our patients. So I'd like to give a huge thank you to my mentors, Dr. Quinn, Dr. Isaac, Dr. Wine, Dr. Carroll, and everyone else in our Edmonton clinic, as well as our Children's Hospital for funding. Thank you.
Excellent. Thank you very much, Alexandra. Are there any questions for Alexandra?
Thank you very much indeed, Alexandra. So I think you've convinced us of the utility, and you've covered quite quickly some of the downsides of it. But in reality, how much time does it take, which adds on to it? People are thinking, right, we must get this from this clinic, we must get the training. But how much time does that encounter get added beyond the standard clinical appointment for each of these assessments?
Yeah, I think that's very important. And I think it really depends on the question, whether you're using it for research, so you have to take many measurements, or whether you're using it just in your clinical practice. So I've seen it be used in 5 minutes, and you could clearly see, oh, it looks quite normal, or wow, this looks very abnormal. So it doesn't have to be a long tool. I think it can even just give you a little bit more information if you're not sure about that patient.
Thank you very much. Any further questions for Alexandra? Okay, thank you very much, Alexandra.
And now we're delighted to welcome Alex Noble from University of Oxford, where she's working with Professor Jack Zasangi and team, and was seduced across the hemispheric line to come to the UK. And we're delighted. She's got this very exciting abstract with a very exciting title, and she's going to tell you about it herself.
Thank you very much. So today I'm going to talk about intergenerational epigenetic contribution and also epigenetic clock in pediatric IBD. Okay, so gene-environmental interactions play a key role in the development of IBD. So we define the exposome as the totality of environmental exposures which an individual is exposed to from conception onwards. Now, these interactions may be potentially mediated by epigenetics. Now, there are several types of epigenetic modifications, but today I'm just going to be talking about one, which is DNA methylation. Now, we know the microbiome and nutrition play a strong role here, but today I'm going to be talking about also the role of passive smoking. So we know that adult smoking has genome-wide effects on the methylome. So tobacco smoking has been consistently associated with hypomethylation at the locus AHRR. Now, this is a biomarker for tobacco smoking, and such that this is actually more accurate than taking a cotinine measure or even asking for a smoking history. Now, this pathway is strongly associated with, it's been strongly implicated in the inflammatory regulation. Now, currently, passive smoking exposure is not very well defined. So we know there are methylation changes associated with IBD. So previous work from my group has sort of defined the circulating methylome, and this work has also been validated in cohorts of North America and also Scandinavia. Now, recently, these results have also been subjected to a systematic analysis. Now, top sites come from genes RP, S6, Ka2, SPNO2, and also VMP1. Now, today I'm going to talk about this study where we looked at the role of passive smoking exposure and how this may play a role in the development of pediatric IBD. We also assessed the component of epigenetic inheritance in pediatric IBD and also looked at the epigenetic clock and looked for evidence of biological aging in pediatric IBD. Okay, so to do this, we used a cohort of individuals from Southampton. So this work is in collaboration with Sarah Innes and her team. Now, we had 90 trios, so this consisted of a mother, a father, and a child with IBD. So we obtained samples from all three of these individuals, and we did methylation analysis using the Illumina 850K epic array system. We also did genotyping. Now, within the mother and fathers, there were subsets of individuals who were both smokers and also non-smokers, and this information was derived through questionnaire at time of recruitment into the study. Now, I won't go over too many of the cohort characteristics, but really I just want to point out we have 59 individuals with CD and 28 with UC, and also highlighted there is the smoking status of the cohort. Okay, so firstly, we wanted to look how many children have been exposed to passive smoking. So if we look here, we see out of the 59 individuals with CD, about 50% of them have had no exposure to passive smoking. Now, when we compare this to our UC group, we actually see 7% had no exposure. So only 2 individuals out of the total of 28 had no exposure here. And this resulted in an odds ratio of 13. And I suppose we sort of conclude here that children exposed to passive smoking are more likely to develop UC than CD in our study. Okay, so next we wanted to validate tobacco smoking in our adults. So here we've got an EWAS study, which is an epigenome-wide association study where we took the smoking parents and compared them to the non-smoking parents. And as you can see here, the most top differentially methylated CpG site is in the gene AHRR. So this is great. We validated tobacco smoking in our cohort in the adults. Okay. So when we assess this in the children, here we've got another EWAS here, but this time what we've done is taken children with definite and uncertain exposure and compared these to the non-exposed, just CD children. And what we can see here is there are several CpG sites within genes which were found to be differentially methylated at a genome-wide level here. Now, of interest, AHRR was not found. So what we did was we investigated this a little bit further, and what we found here was that there was hypermethylation in the children, particularly in that definite exposure group. Now, important to note, in the parents who were tobacco smokers, we found hypomethylation. So this is going in the opposite direction. Okay. So we took this a little bit further and we looked at passive smoking and compared this between, I suppose, child and also father. So here plotted on the y-axis, we have child's AHRR methylation value, and then on the x-axis, we have the father's. And as you can see, we see this weak inverse correlation with paternal AHRR between the locus of the child and the father. Now, we're still working to sort of figure out what is actually going on here because this is quite an interesting observation. Okay, so next we went on to look at epigenetic inheritance. So to do this, we took the top 15 sort of known EWAS sites in pediatric IBD, and we compared them in both the child, the father, and the mother. So the plot on the left-hand side here, it's quite messy, but really we're just trying to show that we did not find any correlation between the child and the father, the child and the mother, and then the mother and the father. Now, this is pretty much indicative to all of the 15 CPG sites that we tested here. So just showing results of RPS 6KA2. Okay. And lastly, we went on to looking at biological aging. So currently there's great interest into biological aging, and the great thing about epigenetics is we are able to measure this. Now, there are many different epigenetic clocks. However, we've just got results from the Horvath clock. So this incorporates 353 CPG sites, which are all located on the Illumina epic array. Now, we compute age acceleration by taking biological age and minusing this with chronological age. Now, in our cohort here of the children, we found age acceleration within our CD group. And of particular interest here was really this group of individuals with high age acceleration. Now, we were unable to correlate these individuals to any sort of clinical outcome. So we are looking into this further, particularly bringing in a non-IBD control group here. So in conclusion, children exposed to passive smoking are more likely to develop UC than CD in our study. We have defined a series of epigenetic changes from exposure to passive smoking in the children with IBD. There was no parental contribution at sites implicated in known EWAS IBD top sites, and also we found evidence of biological age acceleration in children with CD. Okay, so lastly, I just want to acknowledge our team at Oxford, also our collaborators, particularly those at Southampton, and also thank Action Medical Research for providing the funding for this study. Thank you.
Thank you very much. Have we any questions from the floor?
Yeah, my name is Richard Russell. I'm one of the consultants here in Edinburgh. How do you explain your findings? So I think all of the other studies that have been done with passive smoking in children have not supported your results in bigger studies. So is there a quirk in your data? Have you got reliable smoking status from the parents and the children?
So that's a really great question, and I suppose I'm not really, I mean, we take what we've been given, so this is what has been recorded here, and obviously that's a question that we ask often because, you know, it's very easy to lie about these things. I suppose these children and these trios weren't picked based off smoking status or anything like that. They were picked of how many samples do we have a mother, a father, and a child for these individuals. So that sort of in turn makes us think that potentially this is not a bias, but again, I suppose it's hard to see whether or not what they're saying is actually correct. There is, again, very mixed literature currently about whether or not there is this bias here, particularly in IBD, of people exposed to passive smoking. Yeah.
Do you just have, thank you, do you just have blood samples in these families, or do you have any urine samples that you could maybe measure content or something in to objectively support or rebut your findings? Yeah,
so I don't think we do have urine, but it's saying AHRR is a very stable biomarker for tobacco smoking, so we sort of use the methylation results to almost try and validate smoking status, and I mean, we have done that to a degree, but again, having another measure here is always really helpful. Yeah.
Thank you.
Thank you very much indeed. There's lots more questions, but time has run up, so we'll have to let you sit down. Thank you.
Thank you. The next presentation is from Erila Snyder from Canada, and her talk is on the anti-TNF-alpha versus immunomodulators as first maintenance therapy in pediatric Crohn's disease. It's a multi-center prospective cohort study with propensity score matching.
Thank you so much for coming to my talk today, and thank you to the PIBD committee for giving me the opportunity to present my research. I have no conflicts of interest related to today's presentation, but my fellowship at SickKids was partially funded by Takeda and Janssen. As we've all heard a lot yesterday, the prevalence of IBD in Canada is extremely high, and it's predicted to continue to rise at least over the next decade, with the prevalence of IBD in children also rising and a predicted over 12,500 Canadian children living with IBD in 2030. Adult studies have suggested that early intensive therapy leads to greater clinical and endoscopic remission, and limited pediatric data does suggest the same. However, large prospective studies with endoscopic healing outcomes are lacking, which brings us, of course, to my study. Our study was an analysis of data from the ESPGHAN Inception cohort study, which is a prospective cohort enrolling children with newly diagnosed IBD at 12 pediatric IBD centers across Canada between December 2013 and December 2018. The predetermined aim of this Inception cohort study was to comprehensively phenotype patients at the time of diagnosis so that in follow-up, outcomes of phenotypically similar patients treated with different therapies could be compared. For this analysis, we included children with ileal and/or colonic inflammatory Crohn's disease who received immunomodulator or TNF antagonist-based first maintenance therapy following standard induction with steroids, EEN, or TNF antagonists. We excluded those with stricturing or penetrating Crohn's disease, as well as those with isolated perianal Crohn's disease or isolated upper GI Crohn's disease. Those treated with a TNF antagonist solely for perianal disease were also excluded, as well as those with less than 6 months of follow-up. Our primary outcome was a very stringent composite outcome of sustained steroid-free clinical remission and intestinal healing at 18 months on first maintenance therapy. We defined sustained steroid-free clinical remission as a weighted PCDI of less than 12.5 at 6, 12, and 18 months of follow-up without luminal resection and without steroids or EEN from 6 to 18 months. We defined intestinal healing as a resolution of ulcers on 18-month scope for those with ulcerations at baseline, or a normal MRE for those with isolated ileal disease without follow-up scope or without ulcerations at baseline, or a CRP of less than 5 and a fecal calprotectin of less than 250 for those without ulcerations at baseline or without follow-up scope. We looked at a number of secondary outcomes, but for the sake of time today, I'll show you the durability of therapy, as well as linear growth in children who are Tanner stage 1 to 3 at baseline. To account for the confounding bias often seen in observational studies, we use propensity score analyses. Our propensity score was modeled using logistic regression with baseline covariates that were determined a priori based on literature review, which included disease activity, age, height Z-score, perianal disease status, disease location, disease severity on initial endoscopy, and baseline labs. We then used one-to-one greedy matching without replacement and matched within a pre-specified caliper width of 0.2 standard deviations of the logit of the propensity score. We also imputed missing data using multiple imputation. There were 1,420 children with IBD in the ESPGHAN Inception cohort study. After excluding those with ulcerative colitis or IBDU, we had 898 that had Crohn's disease. Applying our additional exclusion criteria, we had 532 that were included in the current analysis, 239 receiving TNF antagonist as their first maintenance therapy, and 293 receiving an immunomodulator. 80% of those in the TNF antagonist group received infliximab, and the remaining 20% received adalimumab. In the immunomodulator group, the majority, 56%, received methotrexate, and the remaining patients received azathioprine. Looking at the baseline characteristics of our entire cohort, there were about 60% males, and the average age was around 13 years old. There were, as expected, significant differences between the groups of patients receiving TNF antagonist or immunomodulator as the first maintenance therapy. Children in the TNF antagonist group were sicker at baseline and had more significant disease. Their weighted PCDI was higher, they had higher SES-CD, lower albumin, higher ESR, higher CRP. They also had a shorter duration of symptoms prior to diagnosis and more perianal disease. After matching, based on the propensity score model that I discussed previously, our groups were very, very similar, and all of these significant differences disappeared. Of course, what I'm showing you is in the matched available cases, but we performed a similar match in all 100 multiple imputed data sets that we formed. Here I'm showing you the distribution of the propensity scores in the observed data, as well as across all 100 multiple imputed data sets. And as Dr. Turner explained earlier, this is done to assess overlap in the range of propensity scores, as this is needed to make inferences about treatment effect. And as you can see from the middle of both of these figures, there's a nice area of purple overlap allowing to make us these inferences. In terms of results, I'll show you results in the entire unmatched cohort as well as those in the matched cohort after multiple imputation. So here I'm showing you clinical remission and intestinal healing outcomes in the entire unmatched cohort. On the left is our composite primary outcome, sustained steroid-free clinical remission and intestinal healing at 18 months on first maintenance therapy. And as you can see, there are many more patients that achieve this outcome in the TNF antagonist group compared to the immunomodulator group. The same was shown in each individual component of the outcome, sustained steroid-free clinical remission and intestinal healing at 18 months on first maintenance therapy. We had very similar results in the multiple imputed data sets after matching, as displayed on the figure, with all of these results being significantly greater in the TNF antagonist treated patients. TNF antagonist therapy was also shown to be much more durable in our cohort, both in the entire unmatched cohort as well as the multiple imputed matched cohort. We had 55% of our patients in the immunomodulator group requiring therapy escalation by 1 year. And of all of the patients, 207 in total, that did require treatment escalation by 18 months, 88% of them were in the immunomodulator group. Linear growth was also greater in the TNF antagonist group, both in the entire unmatched cohort and the multiple imputed matched cohort. However, this only reached significance in the multiple imputed matched cohort, as you can see in the figure. I did want to show you one of our post-hoc analyses, which is clinical remission on first maintenance therapy without post-induction steroids, but only at one point in time, so not requiring to be in sustained steroid-free clinical remission. These numbers are more similar to some of the other studies that we've seen, with about 66% of our patients in the TNF antagonist group achieving this at 1 year versus only 22% in the immunomodulator-treated patients. To conclude, within 1 year, over half of our patients started on maintenance therapy with an immunomodulator required treatment escalation. Despite being sicker at baseline, clinical remission, intestinal healing, and linear growth outcomes were all greater in the TNF antagonist therapy group, even before matching. These results may help and hopefully will help to advocate for better access and funding for early TNF antagonist therapy in pediatric Crohn's disease. We did have a substantial portion of patients who failed to meet our primary outcome despite early TNF antagonist therapy, which may be due to the very stringent primary outcome that we had, but might also reveal an unmet need in pediatric Crohn's disease. Future studies looking at prognostic markers may help to identify the very small percentage of patients that really can achieve clinical remission and intestinal healing on an immunomodulator alone. Thank you so much for listening to my talk, and thank you to everyone that's been involved in this project and at all of the centers across Canada. And a big special thank you to Dr. Griffiths and Dr. Church, without whom this project would not have been possible. Thank you.
Thank you very much, Sheila. Beautiful data set. I have a question from Jiří.
Jablonský, Prague, the Czech Republic. Yeah, very nice study. Congratulations. My question is whether you had a chance to separate the results according to the type of immunomodulator, because you had two very nice separate groups, one on azathioprine and the other on methotrexate.
So I did not do that. I could look at that, but I don't have that result on hand.
Thank you. Any further questions for Sheila?
Here.
There's one up there from down, I think.
Beautiful study, very interesting. Also, you didn't really need the propensity score matching, did you?
No.
The bias was the opposite. But I don't think you refer, and I like your last comment, that all patients need anti-TNF at the outset, right? I mean, there are patients with limited, very mild disease. Can you show in your well-phenotyped cohort what characterized patients on immunomodulators that did have a good outcome?
So I don't have those results. You mean look directly at the that 9% that achieves the intestinal healing that were started on immunomodulator, what characteristics they had at baseline?
Yeah.
No, I don't have that. But that's a great suggestion, and I should add that to my manuscript. So thank you.
Thank you.
Thank you very much, and for the interest of time, let's move on to the next session. Thank you very much.